Adnan, are you here?
Yes, sir.
All right. So yeah, so you started very well, but in knee examination, I will just like to say that if it's a short case, then in knee examination, you want to see inspection findings. After that, on palpation, that's fine. Leave neurovascular and all these in the end. You want to know about the collateral status. If with so much varus deformity, you have a lateral collateral ligament laxity, then you need to change your plan of surgery. So you
Yes.
need to check the collaterals. That was very important. You missed that. And after that, after the X-rays, we need to get full length X-rays to know the mechanical axis. And you all should know about the mechanical axis of the lower limb. This is LDFA angle, and this one is medial tibial medial tibial angle. This one is also MT something. So you know, need to know this angle. If there is varus deformity, so this angle reduces, this increases. If valgus deformity, it goes the other way. So you need to know this.
Okay, sir.
And then in a valgus deformity, you need to think about the planning. You are planning for a total knee replacement. In this case, half of the numbers were for the total knee replacement. So you need to be quick. Your scheme needs a bit of a revision. I mean, I know we are not conducting with the patient, but even, I mean, it should be in your mind at least. And
Okay.
other than that, I think you took a good start. All right. So about the first case, I will say it was a difficult case. I understand you did very good thing. You did the spine, but you missed the gait of the patient. You need to see how the patient is walking. You missed the gait. I think it must have skipped. So keep your scheme in mind, whether you are doing gait after inspection or before inspection. So I think
Okay.
your uh, schemes need to be revised, and that can only be revised on patients. So I know there are only 2 3 days, but do more schemes on the patient. So in this patient, we need to focus on feet, their deformities. You can look at the feet. I can appreciate there are multiple callosities. Patient has a what is this position? Has a 4 foot adduction. I mean, you should describe all these deformities of CTV, cavovarus deformity. Hind foot is in varus, 4 foot adduction, and there is a high medial arch. So take orthopedic names. I mean, describe in orthopedic terms, and that will give a good impression.
Okay, sir.
All right. So best of luck for
Thank
the
you.
exam. And
Thank you. Thank you, sir.
next is next candidate is Jahandad. If he is here, Jahandad, have you joined it? Jahandad, are you here?
Yes, Salman bhai, I'm here.
All right. Salman will take your first strokes.
Hello, Jahandat, can you hear me?
Jahandad, we can't hear you. Can
Yes,
you
Salman
please
bhai.
speak loud?
Speak loud, please.
Yes. Okay, yes, I'm here.
Okay, yeah, good. So, okay, we'll start with the first talks, okay? So this is a 8-month-old baby who has presented with the
Okay.
parents in the outdoor, and they're concerned about the abnormal sound in the
Yeah.
hip. So this is the X-ray. Can you see can you describe the X-ray for me? Jahandat, are you still there?
I think he is not here. He has some problems with his internet connection. So we can go with any other candidate next, please.
Anyone else want to take
Yeah,
this?
sorry. There was a candidate Wajid, or there was another Yakitish. Sorry?
Hello, sir.
Yeah,
Sir, assalamu alaikum.
yeah, walaikum assalam. So yeah, is it Kashitis?
Yeah, Chiti, sir.
Hello.
All right, Kashiti's. Right. Sorry, Siti. I think Jahandad is here. And after
Okay, sir, no
Jahandad, we
problem.
will take.
Yeah.
Irfan, can you mute everyone else?
Yeah, yeah. Yeah, Jahandad, are you fine? Can you describe the X-ray, Jahandad? All right. I think, Jahandad, you are having some problem with the internet. So we will go ahead with Yatish. Yatish, can you please start?
Ji, Assalamu alaikum, sir.
Welcome.
This is the plain X-ray of the AP view of the pelvis, including the bilateral hip joint in a skeletally immature patient, where I can appreciate the left hip
Can you please
dislocation,
bit louder?
where I can appreciate the proximal migration of the left hip out of the hip joint, probably left hip dislocation, sir. Dysplasia of the left hip, sir.
Dyslexia.
Sir, no, double DDS of the left hip, sir.
DDH. Okay, good, good. So what do you know any parameters that you will measure on the X-rays?
Sir, in the AP view, I'd like to measure the Hilgen. I'd like to draw a Hilgen-Renner's line through the triradiate cartilage, and another line I'll draw through the perpendicular line through the lateral wall of the acetabulum, that is known as the Perkins line.
Good.
And I'll also look for the centrum's line, which is the line passing through the inferior border of the superior rim, superior
Okay,
foramen, passing through the medial neck of the femur.
good.
And another line I would like to draw is the acetabular index, sir.
Very good. Do you know the value of the acetabular index?
It's normally it should be less than 25 degrees, sir.
Okay, very good. So can you tell me what are the principles of management if this child is 6 months old?
For the 6 months old child, I'd like to go for the conservative management with the. I'd like to counsel the patient that this can be fairly managed conservatively by with close reduction and public harness application or it is
Okay.
like a
Do you
caster.
know how do we apply public harness?
So there are several components in the public harness, sir. There are chest
Mhm.
strap, shoulder strap, and anterior and the posterior strap to maintain the hip in abduction and the flexion. And the posterior strap will maintain the hip in abduction, and anterior strap will
Can
maintain the
you
hip in flexion.
sorry, can you please tell me what are the steps? How do we apply public harness?
So first we will apply the chest strap, sir,
Okay.
and then I'll tighten the shoulder strap superiorly,
Mm-hmm.
and then I will apply the foot stirrup into the bilateral foot of the patients,
Okay.
and then I will first check the safe zone of the reduction of the Ramsey. So for
Mm-hmm.
that,
Very good.
after checking the safe zone of the Ramsey, I will maintain the hip in flexion up to
Mhm.
90 to 100 degree
Right.
with the anterior strap. And
Mhm.
with the posterior strap, I'll maintain the abduction of the hip, but not more than 50 degrees. Sir. Around 40 to 50 degree of the hip abduction will be maintained.
Okay, very good. So you have applied public harness. How will you follow up this patient?
Sir, for the initially, I will call for the patient after 2 weeks and check for the reduction of the hip. I will do the USC of the hip joint and I will measure the alpha and the beta angle, sir. Normally, the alpha angle should be more than 60 degree and the beta angle should be less than 55 degree.
How will
And
you measure this angle? Sorry, I missed that.
with the ultrasound, sir,
Okay, good.
you
Ultrasound. Yeah. Okay, good. So let's say this is a 8 month old lady, then 8 months old baby, then how will you do? What will you do?
if
Up till
this is
what age you can offer public harness?
up to 6 months, sir.
Okay, if it is a 8 months old child, then what will you do?
For the 8 months child, I would like to go with the close reduction and the hip spica cast application, sir.
Hip spica. Do you know the principles of hip spica?
Uh, uh, the principle of the hip spica is that the hip should be placed in the safe zone of Ramsey, in
Yeah. Do you
90
know
to
the
100
parameters? How much flexion, how much rotation that you need to maintain, and how is it applied? 1 leg,
Yes,
2
sir.
leg, 1.5 leg. How
The
is
hip
it?
spica is applied in one and half hip spica,
Okay.
The opposite knee should be kept free, and for the affected hip, I will do the flexion of up to 60 degree of the hip flexion and 40 degree of the hip abduction. I'm not sure, sir, but I
Are
just
you
forgot.
sure about these figures or you are just guessing?
I just forgot, sir.
Okay, no worries.
Can't remember it.
Okay, that's fine.
Time's up.
Okay, time's up. Okay. I will give you feedback after this. Okay. So,
Yes, sir.
so this is a 25-year-old male who has a fallen from 20 feet height. Okay. Can you describe
Yes,
the
sir.
X-ray for me?
This is the plain X-ray of the ankle joint, including the distal tibia and the fibula and the tarsal bones and metatarsal bone in the lateral view in a skeletally mature individual, where I can appreciate the comminuted fracture of the calcaneum.
Okay.
Uh,
Very good. So tell me what, so if this patient has come to you in ED, okay? How will you proceed?
First, I'll go with the ATLS protocol and I'll stabilize the patient and I'll do the
Okay,
primary
you have done,
survey and
patient is stable, everything is fine. Just tell me what are the things you will look for and what other investigations you will order for this patient.
so I'll also look for the ipsilateral knee joint and
Hmm.
contralateral foot to look for the other fracture in the other joint as well. And
So,
I'll look for the hip joint
okay, so, carry on, carry on. So you
and then
said
I'll check
ipsilateral knee, contralateral ankle. Anything else?
and hip joint and the spine as well. So
Okay, very good. So you have done these X-rays. So this is an isolated injury. How will you proceed?
then I'll take the X-ray. Since this is the lateral view of the ankle, I'll do further imaging of the ankle joint. I'll take the X-ray in the Harris view,
Okay,
the
Harris view, yeah.
lateral view, and
Mhm.
uh,
Do you know any
broad ends view.
angles? Do you know any angles of the
Uh,
calcaneum?
in the lateral view, I'll measure the angle of the chisel uh, and Boller's angle. So,
Bowler's angle. What do they, how do they help? Why do you
if
measure
the
these angles?
Gissen's angle, if the Gissen's angle is increased, it indicates that there is a, depression fracture of the calcaneum.
Okay.
Uh, and if the Boller's angle is increased, then it indicates that
Increase or decrease?
sorry, decrease. Sir. If the
Okay,
angle
that's
is
fine.
decreased, then it indicates that the height of the calcaneum is reduced.
Okay. Anything, any other angle that you are aware, or just these two angles? Do you know any
I'll
other
also
angle?
canal view.
Canal view. Okay, that's fine. Okay. What other investigation you will do, or are you happy with the X-rays?
No, sir. I'll also like to do the X-ray of the knee joint,
No, you have
ipsilateral
done the
knee
X-rays.
joint.
All X-rays have been done. Any other things you would like to do? Any other investigation? Any
I
other
like to do the CT scan, sir. CT scan of the affected ankle and the foot, sir.
CT scan of what?
CT scan of the affected foot and ankle, sir.
Foot and ankle. Good. Okay. Do you know any classification for calcaneum fracture?
Yes, sir. There are two classification system. One is the SX low pressure classification, which defines the fracture as a tongue type or a joint depression type. And
Yeah.
another is the Sanders classification, which is based on the coronal view of the CT scan, sir. And it
Mhm.
has classified into type 1, type 2, type 3, and type 4,
Is
which
it
will
based on the
determine on the
coronal
basis
view?
of the
Is it based on the coronal view?
yes, sir. In the coronal view, we'll look for the
Are you
number of
sure?
the fragment.
Okay. Anyways, so take me through the Sanders classification.
In the Sanders classification, there are type 1, type 2, type 3, and type 4. Type 1 is an undisplaced fracture of the calcaneum. Type
Okay.
2 is a two-part of fracture of the calcaneum, where the fracture line passes from the posterior facet of the calcaneum.
Okay. So you
And
have done
type
the, okay, that's fine. Tell me, how will you manage? What treatment you will offer
as
to this patient?
uh, first, I'd like to measure these angles, sir, and I'd like to assess the as this is a comminuted type of fracture into the intra-articular joint. So I'd like to go with the open reduction and internal fixation with the plates, sir.
Okay. Do you know any approach for the calcaneum?
For the calcaneum, I'll go with the lateral approach, sir. I'll
Mhm.
give the incision 3 centimeter proximal to the tip of the fibula posteriorly, and I'll give a curved. On coming down, I'll give a curved incision, and along the lateral border of the foot at the level of the base of the metatarsal, I'll give a
Very
straight
good.
and deep
Time's
incision,
up.
sir.
Okay, very good, very good. So, sorry, so we'll come to the feedback. Sorry, I forgot. I can't so spell your name. What is your name? Sorry.
Chitij.
Chitij.
My name is Chitij. Yes, sir.
It is okay. It is very good. Your flow was very good, and you have been spot on. I think this is the thing that you need to carry on with your exam. So when you see the basic thing, you know that this is the diagnosis. Just straightforward say it, that this is the diagnosis and this is what I'm thinking. Okay. So with DDH, you were, I mean, you said few words, random words, and then you come to the word that DDH. Just straight away say you. Sorry, but first you said dislocation. I think you don't need to
A
see
proximal
dislocation.
migration. I said the proximal migration of the near
Proximal
hip.
migration, and then you mentioned dislocation. This is not a dislocation. This is an 8-month-old child, so this is a clear-cut case of DDH. Okay.
Yes, sir.
So just say straightforward that this is a DDH. So yeah, you were aware about the public harness principle of management. The We ran out of time, but otherwise I'm going to ask you the what are the principles of management according to the age, and what are the different type of osteotomies, what are the indication of the osteotomies. These are the things they will cover in this DDH station. You were very good with the parameters. You mentioned all of them and you were aware. Very good. And this is it for this one. For the next one, Irfan, can you bring the x-rays of the next one? Calcaneal fracture, again, you were very good. Uh, but the only thing I think I had to just push you a little bit to say, to make you say the words. I know you had all these words in your mind, but you were struggling to say them a little bit. But overall flow was very good, and you know this station very well. You were aware about the angles. So the one angle is the calcaneal pitch that I was
Okay.
prompting you. Okay. If you don't know, that's fine. I mean, you know the angle of Gisane, you know the bowler's angle, which is more important. And then management wise, you need to offer, if it is so you have to, whenever there is a question of management, you have to tell about the non-operative and operative, both options. Okay. Don't jump to the surgery straight away, because most of the examiner don't like if you just jump straight to the uh, again, I would say just tailor it according to the case. Not every case can be managed non-operatively. Don't say non-operative management in a case where you think that it is not an option, okay? But in calcaneal fracture, if you think that the calcaneum is not reconstructable, you don't reconstruct it, okay?
Yes, sir.
I think this is
Okay,
it
sir.
from my side. Anything you would like to add, Irfan, from calcaneum?
No, no, I think, yeah, you have added everything, Salman. Thank you. Yeah, that's great. Should we go to the short case, Kshitiz?
Okay, sir.
Kshitiz, you are taking FCPS or MS or DNB?
FCPS, sir. FCPS.
All right. Kshitiz, this is a short case. So you can see a 16-year-old patient. He is standing in front of you and has been having problems of shoe wear for the last 2 years.
ओके सर। अस्सलाम वालेकुम, मेरा नाम डॉक्टर सिद्दीक है, मेरा सुबह आर्टिचर से। मैं आपके मसले के बारे में कुछ सवाल करूंगा, उसके बाद मैं करूंगा, इजाजत है?
जी बिल्कुल इजाजत है।
हाँ सर, तो आपका मसला ये दाहिनी टांग में या दूसरा में भी है?
तो दोनों पाँव में मसला ये हो रहा है कि 2 साल से मेरे जूते नहीं सही आ रहा है। मुझे लग रहा है कि मेरे पाँव की शक्ल तब्दील हो रही है।
So, okay, the patient is standing comfortably in front of me. I cannot make the adequate exposure up to the thigh, and however, on inspection from the front, I can appreciate the flowing of the toes on the right foot, and on inspection from the side, I can appreciate the patient is landing on the lateral border of the midfoot and the forefoot, and I can appreciate the high arc of the midfoot on the contralateral limb. On inspection from the back, I think there is the cavus deformity of the hind foot, and sorry, varus deformity of the hind foot. And I will also like to look over the spine, and there is there any tuft of ears or any coronal plane deformity of the spine? and I'd like to
So
check
you
for
have
the
done the
any.
inspection and spine is fine. And these are all the deformities you said correctly. What is your next step in your scheme?
Okay, I'd like to look for the gait of the patient, sir. And
Yeah, so patient is walking on the lateral border of his feet, and the stance phase is short, and the heel strike is also not very well visualized. What next?
okay, I'd like to make the patient to stand on the heel, sir.
All right, what next?
Okay, then I'll ask the patient to sit, and I'll check for the plantar callosities, any ulcer over the lateral border of the foot, and then I'll check for the superficial. I'll check for the temperature over the bilateral ankle joint and any tenderness over the ankle joint, the subtalar joint, and any tarsometatarsal joint. I'll also like to check for the suppleness of the ankle, subtalar, and the tarsometatarsal joints. Then I would like to check for the reflexor, bilateral knee reflex. So what is the finding, sir?
All right, so reflexes are mute bilaterally knee and ankle.
Okay, then I like to check for the sensation over the lateral border of the foot, lateral border of the leg, as well as on the dorsum of the foot and dorsum of the first wave spacer.
Okay, sensations are slightly reduced. What next?
Reduced. Okay, then I like to check for the muscle power, sir. I like to check for the tibialis anterior, uh, EHL, EDL, FHL, and FDL, and I like to check the power of the tibialis posterior, peroneus longus, and the brevis muscle, sir, on
How
bilateral
do
foot.
you check tibialis posterior?
I would do the plantar flexion of the I'll do the flexion of the grade 2, and then I'll do slight plantar flexion, and I'll ask the patient to adduct and invert the foot.
Okay,
And by
and
the time I'll check for the
where
tibialis
will be
posterior.
your hands?
My hand will be behind the medial malleolus, sir.
Yeah, that's good. All right, and anything else you want to see? Now we are going to conclude the examination.
Now I'd like to check for the there is the cavovarus deformity of the foot, sir. I'd like to check for the Coleman block test.
That's good. So Coleman block test is what will Coleman block test tell you?
Coleman block test will tell me that if it is a flexible deformity or it is a rigid deformity. If the is the hind foot varus is coming from the forefoot,
Okay,
or I can say that it is a forefoot driven hind
so
foot varus or not.
it looks like it is 4 foot driven. So, all right, after
So
examination, what is your differential diagnosis?
my differential diagnosis is CMTD, sir, Charcot-Marie Tooth disease,
Okay,
and
anything else?
it can be myelomeningocele, sir.
Okay, but the spine was fine.
Spine was fine.
Okay,
Could be a
so
clubfoot as well, sir.
yeah, that's good. So Charcot-Marie-Tooth disease, and what investigations are you going to do?
So I'd like to do the X-ray of the ankle, bilateral ankle in the AP and the lateral view, including the foot as well, to look for any arthritic changes.
Arthritic changes, deformity is 4 foot driven. What is the treatment?
As the Coleman block test is positive, so I'd like to do with the soft tissue procedure, sir. I would like to correct the cavus by doing the plantar fascia release or Stenler's procedures. And then I'd like to do the dorsal closing wedge osteotomy of the first metatarsal. This will correct the cavus deformity. And for the hind foot varus deformity, uh, it is a supple deformity, so I don't have to do any bony procedures. I like to transfer the tibialis posterior to the lateral aspect of the cuneiform, and I like to do the tenodesis of the peroneus longus with the brevis. This will
What is
correct
John's
the
procedure?
Jones procedure also, sir, for the clawing of the toe.
Do you know what is John's and modified John's?
Uh, no, sir, I don't know modified Jones, but I
All
think
right,
Jones procedure is to
that's
transfer the
that's fine. That's fine.
extensor
That's good.
section onto
Let's
the
move to the
metatarsal
next
joint.
case. Heather is back, so Heather will be your examiner for your next case.
Okay, sir.
Okay, hello. May I ask your name? Sorry, forgot.
So my name is Sipis. Sir.
Say it again.
Sipis, sir.
Okay, spit. Okay, so this is 60-year-old patient presented with leg pain and discharging sinus after an open fracture 1 year ago. So yeah,
Okay, sir.
what can you see in this picture? Like,
This is a leg
how will you
picture
examine?
from the tibia.
Sir, is this the picture in the leg, sir? Lateral aspect?
Yeah, yeah.
Okay, sir, I can appreciate the linear scar of around 15 centimeter over the lateral aspect of the leg with where the proximal and the distal part of the scar is held by primary intention. However, in the middle part, I can appreciate a small swelling, which is erythematous, and it has bulged out. However, there is no any discharging sinuses and no any venous prominences over the swelling.
Will you like to examine this patient?
So I'd like to
It's a
examine
case
the.
of open fracture previously.
Sir, I'd like to check whether the scar are tender. Scar are tender. It is tethered to the bone, or they are free. And I'd like to check for the mobility of the. I'd like to check for the continuity of the bone, sir. If the bone is continuous or
Yeah.
there is palpable defect. If there is any palpable defect,
Yeah.
I'd like to check for the tenderness around the bone. If there is any tenderness and palpable defect, I'd like to do the play of the bone in anteroposterior and the medial lateral
Yeah,
direction.
there is non-union. There is movement at the fracture site, and what else will you like to examine?
Then I'd also like to check for the lymph nodes, sir, for to rule out any
Yeah.
active infectious condition. And I'd like to check for
Okay.
the sensation distally. And
Yeah.
if there is the play over the fracture, then I'll assume that is a non-union. So I'd like to go with the imaging and the lab works investigations.
Okay. Anything else in the examination you are interested? Okay. So regarding the what else? How will you manage this patient next?
So I'd like to do the X-ray of the leg in the full length of the tibia and fibula in the AP and the lateral view, sir. So this is the
Yeah.
X-ray of
So
the yes, sir. This is the X-ray of the tibia and the fibula in uh, skeletally mature patient in a AP view and the lateral view, where I can appreciate the uh, gap over the proximal third to middle third junction of the tibia with sclerotic margins, and I cannot appreciate the corticomedullary differentiation proximally and distally to the fracture site. And the fracture, there is also the non-union of the fracture site, and I can also appreciate the tibia and the fibula being in continuity with the callus. I think there is a fusion of the tibia and fibula at the fracture site, and I can appreciate the implant distally to the fibula, which is well secured and healed fracture site.
okay. After the X-ray, how will you proceed then further?
I'd like to do the lab work, sir. I'd like to do the CBC, ESR, CRP to rule out the infection.
Okay, the inflammatory markers are high then.
If the inflammatory markers are high, then and then I'd like to counsel the patient that the patient first I'd like to counsel the patient that the patient may need the adequate antibiotic coverage for the infection, and if it resolves on its
Any other investigation before going on treatment?
so I'll also like to send the post for culture and sensitivity and histopathology as well, tissue for
Okay.
histopathology.
Any radiological investigation to see for infection in the bone?
I'd like to do the MRI, sir.
Okay, MRI scan. Okay. Now coming on the treatment, there is some osteomyelitis element of osteomyelitis as well, and there's established non-union. How will you proceed then further?
If there is established non-union, then I'll counsel the patient that the patient is likely going to require the surgery. So I'll take the proper
Yeah,
consent
patient
and
is
explain the procedure.
willing to go ahead. Yeah,
Yes, sir. Then I'll
patient is
take
willing
the
to go ahead. So what procedure you gonna offer him?
I'll take the patient to the OT and do the painting and draping, and I'll keep the incision over the fracture site
Okay.
medially, and then
What are you planning to do? What surgery
sir,
you are gonna do?
I'm planning to remove all the necrotic and infected foci of the non-union site, sir, and
Yeah.
all the fibrous tissue adjacent to the fracture site. I'll send those for the culture and sensitivity and histopathological examination,
Yeah.
and then I'll do the
And
meticulous debridement of the affected non-union site. And then for
yeah.
the time being, as there is the active infection, I'll put the cement spacer over the defect so as to cover the defect and to provide the local antibiotic coverage. And then I'll apply the external fixator proximally and distally to stabilize
Time's
the
up.
fracture.
Time's up.
Okay,
Heather.
yeah.
Feedback, please.
Okay, okay. Yeah, feedback. Okay, so yeah, it's a very common case, very common, especially in Pakistan, and like every hospital is loaded with these type of cases. So I think you need to be very quick in these cases. Like you should have everything on your fingertips, and in the examination, you should have been a bit more thorough. Uh, like any patient is using any walking status, any brace, or like the proximal and distal joint, the status of the in the examination is very crucial. Long-standing non-union patient may have contracture at the knee joint, contracture of the ankle joint, stiffness around the joints, and the examination of the local skin as well, any teeth ring, or other than that, yeah, the investigations, MRI scan is very basic in infection. You need to know about the extent of the infection, how much canal is involved. Yeah, you did about the bloods and the cultures definitely from the beginning. We need to know about the organism, and after that, you can describe different treatment options. What are you planning? Like you can jump to the one treatment, but it makes a good impression if you just give some plans like I can do this, and this will be my preferred treatment. Like we can remove this all necrotic piece and can start with the segment transport or mesculate technique, or like the using the bone cement as such. And regarding the bone debridement, you need to be a bit thorough, like for what will be the extent of the bone debridement, like the paprika sign, how much bone I will take it off, and the maintaining the continuity of the medullary canals is very crucial in these cases. Yeah. So during the surgery, you need to mention it that I will open up the canals on both sides, and limb length discrepancy in the examination you missed as well. It's a non-uniform 1 year. He may have shortening about 2-3 centimeter as well. So yeah, treatment it takes long. You can mention external fixator, Ilizrovs as well, to get the union. So yeah, they're common things, but I think you just need to go through your key and rehearse it a bit more. Yeah.
Right. Thank you, Heather. So, Kshitiz, as Heather has rightly said, I will just add one thing. So, when you feel you are lost, so just give the examiner the principle. So, when he asks you about the treatment, it took you a lot of sentences. So, say the principles of management are extensive debridement, surgical stabilization, and continuous treatment of the infection, and later on rehabilitation and reconstruction. Or you can just say debridement, surgical stabilization, and continuous treatment of infection. So then he will go to the options. If he knows that you know the principle, you have told him that this is the principle, this will give a good impression. And the examination of non-union, it's a long case. Sorry, we have to conduct short case because online conducting a long case is not that much fruitful and a bit boring for candidate and the examiner. So whenever you have a non-union, you need to know the general status of the patient, his nutrition, his health overall, and if it's a long case, you will ask about the history. And as Heather has rightly mentioned, you need to know the joint above and below status, contracture, scan, and his mobility. How is he mobilizing? So this is a long case, but and in treatment, just be concise, show you know the principles. And if I come to my short case, so this was, I think you know very well about Charcot-Marie-Tooth disease. Before making the patient to sit, I would have expected to use the Coleman block test first, because this is going to dictate our treatment. But overall, you did very well. So in this examination, I will start like you did. I will do the inspection, will mention all the findings from front, side, back, and then I will ask the patient to start walking gait and do the Coleman block test. Then I will ask the patient to sit down. And in this examination, you should have a good command on testing the muscles, tibialis anterior, posterior, and peroneal, because there is two strong muscle, two weak muscles. And if we are going to do the tendon transfer, I appreciate that you are very much keen to do temperature tenderness, but that's a less priority. Tailor your schemes. You did very well about the neurovascular examination. I will also add, if you do the hand examination for the nerves, because there is clawing and other nerve involvement. Other than that, you did very well, and well done, and best of luck for your exam. I'll go with the next candidate, that is Wajid Noor. Wajid, I'm your examiner for the oral talks. Are you ready? And I think we will run out of time after this case. I will send you the next Zoom meeting, and I think it's been more than 3 hours. You guys will be bored as well, so we will conclude in the next meeting. Wajid, are you here? Wajid. Yeah. Wajid, can you hear me? I think you are here in the meeting. Can you guys hear me? If
Yeah, I can hear you.
Okay, Wajid, you want to go ahead, or we should go with any other candidate if they want to. Otherwise, we can conclude the session as well in the next. We have done so far 6 candidates with 24 cases so far. Anybody wants to go ahead? I'll share the next meeting link, and then we will each of us, me, Salman, and Heather, will give you tips for 5 to 10 minutes each person, and you can type your questions in the chat box and we will answer those questions. I think we don't have candidates, so I'm going to send you the next link, and please join and prepare your questions. We are going to answer your questions. So I'm going to end this meeting and send you the new link.
Okay.